Good afternoon. Welcome, everyone. Welcome to the webinar Thriving in Substance Use Disorders, Service Delivery in the Post-COVID Era. This is our second part of our webinar series. And as some of you know, this is a training brought to you by the Center for Substance Use Training and Telementoring, CSTAT, in tandem with the Texas Health and Human Services Commission, with the intention of exploring the intersection between COVID-19 and substance use disorders. And to that end, we brought together a group of leaders, experts, including behavioral health professionals, prescribers, and other leaders in the field of healthcare to bring you the most recent information, informing you of the most recent trends in COVID-19 as it relates, of course, to substance use disorder nationwide, but with a focus on Texas, of course. But before we start with the session, I want to briefly remind you that this session is being recorded for later distribution, and you may find this session at our Be Well Texas YouTube page. Also, there is a Q&A box in front of you. We invite you to use that box. This is for you to add there your questions, and our speaker will address those at the end of his segment. So today we have Dr. John Weems. Dr. Weems is probably familiar to some of you. He is one of the hub experts at the TexRx Eco Series here at CSTAT. Dr. Weems is a graduate from Harvard Medical School, and he's an assistant professor of internal medicine at the University of Texas at Austin. He is the recipient of several important accolades, one of them being the Bain Young Physician with the Travis County Medical Society. So it's a pleasure to have Dr. Weems with us. Dr. Weems, nice to see you. And whenever you're ready, I think we can start sharing your presentation.
Wonderful, Andrea. Thank you. Can you hear me okay?
Yes, I can.
Perfect. Let me share. And can folks see the slides here?
Yes, we see them.
Great. Thanks, everybody, for having me. I'm excited to talk to everybody today about some of the changes that have happened over the last few years in service delivery, and particularly with a focus on some like how telemedicine has changed the landscape of substance use disorder treatment. So I'm first and foremost a clinician, and I want to start out by saying that, you know, in some ways, the changes we'll discuss today have just fundamentally changed my practice. I practice in a federally qualified health center. I'm here in Austin, and then under the Be Well Texas umbrella, along with our Shout team members and sites, we also are engaged in assisting teams in hospitals to do hospital-based opioid use disorder care. And across those settings, it's just clear that things are changing, and they're changing really fast. And with that change comes we'll have new ability to serve our patients, and particularly to reach them via telemedicine and deliver what we know are evidence-based ways of helping people get their life back to live and to thrive. And also with that change comes a sense of loss and grief, and not being in the same room with patients it's just a change. It's new and different. So I welcome other people's experiences, and like Andrea said, the chat is open, and we'll have a good amount of time at the end to talk through questions or just insights people have had as they've seen these changes implemented, and then our experience as clinicians, particularly living through these changes. All right, so with that intro, I don't have any disclosures, and you'll see the personally, and there's some team disclosures there. And then our objectives today, we'll analyze some trends in substance use epi since the onset of the COVID-19 public health emergency. We'll summarize some key updates in SUD treatment protocols with a focus on methadone take-home policies, telemedicine for buprenorphine prescribing, and approaches to screening and treating unhealthy alcohol use. And then finally, we'll develop some actionable strategies together to support the workforce well-being while navigating these rapid changes. All right, so I thought I'd start with this. Kind of even before the onset of the public health emergency, we know we had a large implementation gap. While methadone and buprenorphine in particular have been shown to reduce mortality across settings and for decades, very few of particular fellow Americans have access to these. So what you'll see here is a paper from 2022 that estimated that treatment gap. And going top to bottom, you see the dotted line there is an estimate of the probable number of Americans with opioid use disorder, which was in the 10 million range. And then below, you'll see the reported number of OUD, folks with OUD by the National Survey on Drug Use and Health. And then at the bottom there is the line of people receiving medications from a large data set of pharmacy dispensing. So no matter whether it's the reported number of people with opioid use disorder or those of us who probably have it, if you look at estimates, there's a gigantic gap. And this preceded COVID-19 and all the disruption that came with it. If you drill down in the data, and this is a report that came out a year before last, within access to treatment, this gigantic gap, there are many iniquities. And so what this study looked at was the Medicare population and clear-cut inequalities in who has access to these evidence-based interventions. So this cohort of people are folks who presented to the emergency room after an overdose or another opioid-related event. So the sickest folks with opioid use disorder problems that come to medical attention. And what the figure 8 there shows is that and again, this is all before COVID-19. As if you look at every single quarter, people presenting with overdoses or an index event, how many of those people got buprenorphine within 6 months afterwards? And the first thing I'll call your attention to is look at that y-axis, right? So this tops out at 35%. So fewer than a third of people are getting access to buprenorphine, which is a travesty and consistent with what we saw on our prior slide. And then every single quarter along the way, right, there is a statistically significant difference if you're white or if you're Black about whether or not you were offered this life-saving treatment. And you can't look at this and not be convinced that if we're going to do addiction medicine, we're going to do it well, we have to have our eyes on equity, because access to treatment is not and has never been equal. Figure B there is asked the same question with regard to naloxone. And again, it is clear that dispensing naloxone, which is one of the most straightforward, low barrier things that healthcare settings can do for folks at risk of, or in this case, having suffered an opioid overdose, we still can't do it for more than a third of patients. And again, there are significant differences by race in every quarter of the study period. So this is another figure that I hope is familiar to folks, describing the 4 waves of the overdose crisis in the United States. And I won't get into too much depth, but just to point out, right, that in 2019, the trends that worsened during COVID were already underway. We saw an increase in the number of overdose deaths related to fentanyl, and then as well as overdose deaths related to fentanyl and stimulants. So the so-called 4th wave of our polysubstance crisis that's taking so many of our loved ones. So a lot of talks about substance use disorder, particularly in the US, have a lot of figures like this that go up and up as you move to the right. They get the numbers of folks lost get taller and taller. And I just kind of want to like bring it. Let me show you just one more. Sorry, I wanted to show this. This is from an advocacy group called A Song for Charlie, and it's one of many family advocacy groups of individuals who have lost family members to overdose. And it tells an important story here. So if you look at the blue line, that is the percentage of students reporting initiation of illicit substance use. And one story that doesn't get told enough is teenagers are using drugs less and less. And despite that, you'll see the story that the yellow line tells, which is the number of drug-induced deaths. That rate, it continues to increase. And again, it's driven by fentanyl. and that the rate of rise has risen significantly since the onset of the COVID-19 public health emergency. So again, another story told with numbers that say that we're losing more and more of our loved ones. And now this is where I was trying to transition. So this is from our clinic, our FQHC-based addiction medicine clinic. This is our butterfly garden, where we honor those people whose lives we've been privileged to be a part of who are gone too soon. And so again, with these figures that sometimes the individual stories get lost, and I just want to hold open a little space because I'm guessing a lot of the folks on this call are engaged in direct care, and we have a lot of grief and loss related to this. And these are individual people with stories and lives that were cut off far too soon. We're not alone. The scale of the crisis is such that 42% of us personally know someone who's died of an overdose. Another way of sort of describing the scale of suffering here is a recent study pointed out that 320,000 children in the United States in the last 10 years have been orphaned by overdose. And so we know that overdose is it is the headline, it is the story that we're most often talking about because it's just so tragic, and the implications for families and communities are so severe. And that's just the tip of the iceberg. The suffering related to folks who are struggling with substance use disorder, don't have access to treatment, is profound. So this is our butterfly garden. This is our moment of remembrance for these individuals. The last figure I'll show is an encouraging one, and I think frames the three big changes in substance use delivery we're going to talk about. So what this is counts of provisional overdose deaths, and finally, maybe the wave of deaths is slowing. And so clearly, at the beginning of 2024, the provisional counts show across the United States with some heterogeneity, but there is finally a slowing down in the rate of rise of overdose deaths. It is still far too high. These are individuals who we knew and loved, and there are individuals we know and love now who are at risk. And so the work continues on. The changes that we're going to talk about today, hopefully, have been some of the factors that have helped the slowing of this surge, and particularly increasing access to methadone and buprenorphine. So we will start with a case. I want to give everybody a second to get yourself in the mindset. Remember this at the very beginning of the public health emergency, where there was a ton of uncertainty. Things were changing very quickly, and all of us engaged in patient care where things were changing every single day. We're just living in the stress. Can we get things from the grocery store? So in that context, I'll introduce a case. The details have been changed substantially. But this is the story of a 44-year-old woman with opioid use disorder and early remission on methadone, who had a long hospitalization and received several months of IV antibiotics for a serious infection, a spinal epidural abscess. She was discharged in May of 2020, was staying with her mom. She was well supported there, and her goal was to get back to work. She is a painter, and she had an upcoming few jobs a few towns away to build rocket silos. That details just to bring us here to Central Texas, South Texas, bring us back to Texas. And then the setting here is this patient is presenting to established care at an opioid treatment program, or NTP, so come here in Texas. All right, so one question that might cross your mind is, can we start methadone in the hospital? This was not a change to delivery that happened in COVID. It has always been the case that specialized certification or licensure is not required to administer methadone to hospitalized patients. And in fact, being in the hospital is a big opportunity to offer and initiate evidence-based care for opioid use disorder. What you'll see here is a methadone administration quick start guide we at Shout developed along with our colleagues at Be Well Texas under HHS to give clinical teams guidance about considerations to make about initiating methadone in the hospital. And that's what happened for this patient who presented, like many of our patients do, with complications of their addiction, and in this case, a serious bacterial infection related to injection drug use. I should say the QR code, there's going to be a bunch of QR codes throughout, and the idea here is to, I think everybody will have access to these slides, I hope, and if there's a resource that looks like it could help you or your team, I just want you to be able to access it, and those QR codes are live. In fact, you know, some of our national organizations have pointed out that methadone, in particular, starting methadone in the hospital is an opportunity, and not starting methadone in the hospital is something we do for no reason. So this is a series in the Journal of Hospital Medicine, and they pointed out, and this is during COVID, Marlene Martin and colleagues, that, you know, this is a great opportunity to start people on methadone. And in fact, during COVID, we've had some data suggest that methadone is likely more successful at retaining people in treatment relative to even buprenorphine. And so we should all be thinking about how do we set up systems of care in the hospital so that we can initiate folks on methadone if they wish. So here we are, it's 2020. This patient started on methadone in the hospital. They're doing well, and they present to our NTP partners to establish. So in March of 2020, many of us received this letter from Texas HHS and our SOTA, which started here in Texas, like was started across the country, a natural experiment in methadone policy. Because of the imminent risk of getting COVID-19, and a lot of our folks on methadone have comorbidities that put them at high risk for complications of COVID-19, particularly in this pre-vaccine era, and when we didn't have as many of the treatments that we have now. Both federally and then at the state level, there was a a change in regulations to increase access to methadone. The one we're going to talk a little bit more about today is a change in how take-homes are administered and adjudicated. Right now, talking to some of our methadone partners here in Travis County this week, the changes described in this letter are the active changes that clinic directors are working off of currently, and we are in a place where we're awaiting further guidance from the state of Texas about how some of the national changes in methadone regulation are going to be implemented here in the state of Texas. Let's talk about some of those national changes and some of the data that informed them. So what you'll see here is a blog from Nora Volkov, who's the director of the National Institute on Drug Abuse. And she discusses some of this data in a post titled "To Address the Fentanyl Crisis, Greater Access to Methadone is Needed." And she calls for fairly substantial changes. Some of the data that she's looking at, and that had, you know, there had been concerns for many years that increasing take-homes would lead to increases in diversion and other harms. Studies done by the researchers at the CDC and elsewhere show that there was no evidence of increase in diversion, misuse, or methadone-related morbidity and mortality during this time where we had significant changes in take-home policy. There were positive responses for both patients and providers, and in many cases have shown to have improved retention and treatment. And retention and treatment, we know, is one of the most useful indicators of, because we know when people are on medications, their risk of overdose plummets. And so if we can retain people in care, we're improving their chances of surviving and thriving. So that's what the data told us. And just last year, SAMHSA following this guidance, had sort of stated their updated priorities when it comes to methadone regulations. Those priorities are to address the current opioid overdose crisis in the U.S., to increase access to life-saving treatment, and to reduce barriers to MOUD. This in the next couple slides comes from a team at NYU called the COMET Project. And if you're working with or at an OTP and thinking about how to implement some of these changes, they have a great set of resources there at that QR code. This is where the rubber hits the road. The changes in methadone take-homes are thus: if for patients establishing at a clinic within the first 2 weeks, they're eligible for up to 7 days of take-homes. From day 15 to 30, they're eligible for up to 14 days of take-homes. And then after 1 month in treatment are eligible for up to 28 days in take-home medications. There's also been a change. So the 8-point criteria with which many of us were familiar from training and practice have been shrunk to 5 points. And I think this, among all the changes, really kind of captures the sea change in approach. So in the old regulations that hadn't been updated for decades, one of the criteria was an absence of recent abuse of drugs, opioid or non-narcotic, including alcohol. The new criteria is absence of active substance use disorders, other physical or behavioral health conditions that increase the risk of patient harm as it's related to the potential for overdose or the ability to function safely. So those of us who've gone through medical training and all the standardized tests know that, you know, the answer choice with the longest stem is usually the right one. And I think in this case, this is the right approach as well, and it captures so much nuance, right? These changes are not, you know, kind of heavy-handed, give people bottles and get them out of the clinic. These changes allow for a much more nuanced, individualized approach to care. And in particular, this change in criteria, right? Getting from a place where we're looking at if somebody has drugs in their life at all to whether or not they have an active substance use disorder. This is the work we do as clinicians. There's diagnostic work to be done. Most people who use drugs don't have a use disorder, might not even have problems related to that drug use. And when we're thinking about stability for take-homes, adding this nuance and then really thinking again like clinicians, like, you know, is this somebody who is safe? Is this a safe option? The new regulations empower and encourage that kind of clinical patient-centered thinking. This is from Dr. Ruth Potee, who's been such a vocal advocate for patients on methadone and for changes to policies. And this, I love this figure who I think originated with Dr. Kim Soo. And what shows is the spectrum of drug use, right? From managed use, from abstinence to managed use, all the way to the most severe substance use disorder, which is often a daily chaotic use. And, you know, those of us, you know, I was in clinic yesterday morning, I am so used to the right side of this spectrum, right? And a lot of times when patients present to care, that's where they are. They're coming for a reason. Something has gone wrong and the way they were living is unsustainable. And those of us who are in treatment, we know that treatment works. People get better. And just because somebody still has drugs in their life doesn't mean they stay on the right side of this spectrum. And often patients are in the blue, right? There is drug use that's not causing problems in their life. And those patients are, these new criteria for take-home methadone acknowledges this and allows us to understand our patients better in their context, understand their strengths, and have conversations with them about what is the appropriate intensity of care for them. And I think that has been a good change. So again, this evolving approach from historical, highly regulated set criteria where patients are made to earn privileges in a way that's uniformly administered, and the goal is always abstinence. That approach has evolved to one that is meeting patient needs, acknowledging that we're in the midst of an overdose crisis, incorporating more flexible approaches that are patient-centered, allow us to individualize treatment plans and reduce the harms our patients are experiencing. What you see here is on your right side is Dr. Potee's team in Western Mass has developed a set of documentation tools for both a substance use disorder assessment, and then they also show their take-home bottle policy. These are free, and you know, she gave a great talk at ASAM last year where she encouraged people to use this as much as they saw fit to, again, implement what is a rapidly changing set of regulations when it comes to take-homes. All right, so remember that our patient, to head back to the case, she had been in the hospital for a number of weeks, had gotten to a good dose and was in lengthening remission. on methadone. She was meeting her goal of abstinence from street opioids, and at the end of this part of her story, she's on 120 milligrams of methadone daily, and after being at the clinic for a month and continuing to do well, she was on 28-day take-homes. Then the next chapter. So in 2023, this individual who's still in sustained remission now on methadone moved out towards Marfa for work. And she calls the clinic up and says, are there any options to continue on medications out here in West Texas? Just as a side note, when I was kind of crafting this case, I looked at a number of places like rural parts of Texas where I have family. And I was really heartened to find that there's a lot more access than I expected. And we know that through Be Well Texas, there's telemedicine access to buprenorphine for folks across the state. And there's also a lot of brick and mortar available. So that was encouraging part of making this talk. Back to the case, this patient has moved west pretty suddenly, and they're hoping to continue on medications with your team. So this has changed a lot. So can we continue? And again, we're shifting to talk about buprenorphine, or I want to be really clear, buprenorphine, not from an OTP, but buprenorphine care. This is what this patient is interested in. And this has changed so much. So what you'll see on your left is guidance from the DEA, a proposed teleprescribing set of rules. And it's kind of confusing. Thankfully, this set of proposed rules got a lot of feedback from clinicians across the country who pointed out a lot of the implementation barriers with this particular approach. And the bottom line right now, we'll talk in some detail, but the flexibilities that have been in place throughout the COVID-19 public health emergency are still in place and were recently extended until the end of this year, so December 31st. 2025. So to review that, the Ryan-Haight Act, which was enacted in the early 2000s in honor of a young man who had gotten controlled substances online and passed away, I believe, of an overdose, which limited the prescribing of controlled substances via telemedicine to patients who had already established in person with some additional criteria there. The Ryan-Haight Act was effectively loosened during the public health emergency, so long as prescribers were acting in their usual course of practice, the treatment was delivered by a telemedicine, and the practitioner was acting in accordance with applicable state and federal laws. These current policies are extended through the end of this year. But some other changes that had happened that came to bear on telemedicine are in active states of change. So one of them is very early on, the platform for delivering telemedicine. There was a period of time where those did not need to be HIPAA compliant. That we have swung back. So if you're doing telemedicine, it needs to be HIPAA compliant. And then the final point here, 42 CFR, there were temporary changes. Now there have been very substantial changes to 42 CFR, which are posted, and I bet a lot of teams on this call are implementing currently. There are major changes in payer reimbursement. We, at our health system this week, we are dealing with newly implemented changes to payer reimbursement, particularly commercial payers, some in the Medicaid space, with regard to appropriate documentation for utilizing telephone versus video televisit. That is a very complicated scene that's really in flux. And there's also been changes to OTP rules and regulations. So all these have changed or in a state of change. The next couple of slides, we're really going to focus on buprenorphine care via telemedicine outside of the OTP, but I also just want to acknowledge there's been so much change, and these are all very active areas. And in some cases, we're awaiting sort of final rules. All right. A lot of data with evidence was generated this time about telehealth provision of buprenorphine. And the weight of the evidence is clear that telemedicine increases access, engagement, and patient satisfaction. There's comparable or even improved retention relative to care as usual. So when you overcome a lot of the logistical barriers of patients getting to the clinic and do the clinical work over the phone or video visit. No surprise, patients are able to go about their lives as parents, people who work, community members, and still remain in care. This was demonstrated, and again, this is Dr. Jones and colleagues at the CDC in a large study in JAMA Psychiatry showed that telehealth provision of buprenorphine was associated with a decrease in overdose risk. And the final point, and this is Drs. Martin and Williams pointing out that telehealth provision of bupe has the potential to address longstanding inequities in buprenorphine receipt. And I put here a quotation from their piece in Health Affairs. Telehealth for OUD is the only proven example we know of that accomplishes the quintuple aim of enhancing patient experience, improving population health, reducing cost, supporting the workforce, and achieving health equity. And so I've heard it said before, and I think there's something to it. Telemedicine provision of buprenorphine is one of the most substantial changes to in addiction medicine in the last 10 years and maybe more. I think most of us are in the middle of implementing or sort of revising our telemedicine protocols. I wanted to point out this really helpful toolkit from PCSS and SAMHSA, which is a how-to guide for synchronous video conferencing and telephone visits when you're doing buprenorphine care. Because a lot of us, I think all of us have worried, are we still continuing to deliver the same quality care over telemed? And this guide really helps you and your team think about how to answer that question with a lot of nuance. And I found it incredibly helpful for teams that are actively still working on these issues. During the COVID emergency, we also saw the end of the X waiver. And if you don't know what that is, great, forget about it. But most of us probably remember that there used to be a whole separate way that buprenorphine was regulated relative to every other medication, and it's gone. And the question when it was gotten rid of was, now that more doctors and prescribers can get patients access to a key treatment, will it help? And the early provisional answers sort of tell us that innovations like getting rid of the X waiver and enabling and empowering telemedicine for buprenorphine provision, they are necessary, but probably not sufficient to continue to bend that curve and lower the overdose burdens in our communities. There was a report last year in the New England Journal that sort of looked at this, again, using pharmacy level data. It looked at, so what you see the dotted line going top to bottom here is the end of the X waiver. And they're asking the question of, were there more prescribers and was there more prescribing of buprenorphine? And there were more people prescribing bupe as a result of the end of the X waiver, which is good news. And then, does that get us where we want to go so that we're increasing access to care? And unfortunately, again, probably necessary, but not sufficient in and of itself. So just see here on the top is the monthly number of patients to whom buprenorphine was dispensed, and the line is nearly flat. There were more initiations of buprenorphine. This was a modest effect there, and that's what you see in the bottom figure C. And look, telemedicine was likely a big part of this, right? The fact that we could engage patients where they were at. I can say clinically, that's been my experience, and I think that's what's showing up in this data. We were able to get patients on medication, but the scale of this change was again, not sufficient to have the impact we know wider access to these medications can have. All right, so to end this part of the talk, this sort of second leg where we talked about buprenorphine, changes to buprenorphine telemedicine, this 47-year-old woman with opioid use disorder and sustained remission on bupe was receiving ongoing care via telemedicine. Now, if you're confused by one of my typos here or about the situation, right, this patient is on methadone, how are they on buprenorphine now? And you're thinking, how do I help patients through this transition? I just want to give a plug for another one of our guides, again, published with Be Well Texas under HHS and our Shout team, where we describe a shared decision-making process and concrete clinical guidance about transitioning patients from across MOUD, buprenorphine and methadone specifically. And if you want to bring this into your practice, it's a great place to start. All right, last stretch here, we'll talk about alcohol. So back to 2024. So now our 47-year-old with OUD and sustained remission on bup presents to established care and primary care now. During their pre-visit social determinants of health screener, they screen positive with their audit C for unhealthy alcohol use. They are drinking 2 glasses of wine with dinner. They've had no consequences or issues with control. And so because you're a clinician who was really excited by the news, I think last week or the week before, that the U.S. Surgeon General has come out with a statement that reaffirms what we've known for a long time, that alcohol is the 3rd leading cause of preventable cancer deaths in the United States, and that alcohol should be labeled as a carcinogen. You start to talk to your patient about cancer screening, and particularly breast and colon cancer screening. This is not an uncommon story. So we saw across treatment settings, alcohol-related deaths rose substantially during the COVID-19 pandemic. And these trends were already underway. What this figure from JAMA shows is alcohol-related deaths per month on the y-axis, and then dates and months on the X. And the dotted lines show the beginning of the public health emergency in January of 2020. And those deaths in 2020 really started to take off. Lack of access to, and the drivers are familiar, all of us, increased despair and lack of access to treatment being cardinal ones. In some years, including 2020, the rate of rise of deaths related to alcohol exceeded that of the rate of rise of deaths related to respiratory infections like COVID-19. And the absolute number of deaths for many age cohorts, were greater for alcohol-related deaths than COVID-19 in some cases. And so this is a burden that we will be addressing through probably the rest of our careers, is both cancer-related mortality, but also a number of other clinical conditions related to alcohol use. I couldn't help myself. I just wanted to get into a little bit of the details about the specific cancers that have been associated with ethanol exposure. So, and some of the pink figures are from the new Surgeon General's report. So the consuming alcohol increases the risk of developing at least 7 types of cancer. I think folks pretty readily think of liver, but I think it's less well known that breast cancer in women your risk of breast cancer increases stepwise with the amount of alcohol you're exposed to. Other cancers, including cancers of the mouth and throat, the voice box, as well as the esophagus and colon, are associated with exposure to alcohol. And again, alcohol drives a substantial burden of cancer deaths in the U.S. and across the world. I really like these figures, and I wanted to talk about them here in this interprofessional audience, because I think just looking at them together, like sitting with a patient, it can be just so powerful to sort of drive these points home. So we know that higher alcohol consumption increases alcohol-related cancer risk in women, and the risk in women is substantially higher than that in men, which has to do with a number of reasons. And I should say the epidemiology is really starting to capture this. For decades, there was a substantial gap in women and men when it came to heavy drinking and alcohol use disorder. That gap is closing substantially, and that's helping drive cancer incidence. So so what you see here, the 3 colors, right? Like less than 1 drink per week, a drink a day, and then 2 drinks a day. That is the more ethanol, the more alcohol somebody's exposed to, the higher their absolute risk of cancer. And it would be nice if drinking within the prior recommended limits of fewer than 7 a week for women under 65 and everybody over 65, or fewer than 14 a week for men under 65. It would be nice if those drinking levels were safe from a cancer perspective, and it's just not true. There are a lot of this can be a very nuanced discussion. There's been some really great pieces out in the last couple of weeks about the role of alcohol and culture in our society. But in healthcare, I think we should be pretty clear about what we know when it comes to cancer risk, and this is what we know. So what do we do about it, and what does that have to do with changes to care delivery since COVID-19? So again, the recent statement from the Surgeon General makes clear that this figure, which is now 20 years old from the New England Journal, that there's a spectrum of alcohol use, and the only place that is absolutely safe from a cancer risk perspective is abstinence. And then as you head up to low risk use and risky use, problem drinking, and then up to alcohol use disorder, there's an increase in cancer risk. And that's not the whole story. People make their health decisions for lots of reasons. And the good news is that treatment for heavy drinking and alcohol use disorder is effective. It's really underutilized. And we know that the number of people who are at risk in the United States is substantial. So the latest estimate from the National Survey on Drug Use and Health was that I think about 45% of Americans are in that unhealthy use part of this figure on an annual basis. And then it's about 14% of us with an alcohol use disorder every year. And so the recommendation from the United States Preventive Services Task Force has been for a number of years to do universal screening for alcohol use disorder and evidence-based interventions for those with unhealthy drinking or AUD. I'm going to make one quick point here before we head in. Again, this will be the final stretch. So the vast majority of people who are at risk for these cancers and other negative health outcomes, they drink too much. They don't have a drinking problem, if that makes sense. So there is heavy drinking by volume, but there is not ongoing use despite negative consequences. So there's not an alcohol use disorder. And so we really think about two different tiers of intervention when it comes to identifying folks in this unhealthy use world. This is work done at federally qualified health centers here in Central Texas, mostly at community care. And it was a great partnership with folks across Dell Medical School to bring that recommended screening and then telephone-based interventions for unhealthy alcohol use in our health centers. Our key findings was that it was feasible to implement universal screening with an audit C, that bilingual social worker-led telephone outreach provided brief interventions was also feasible. We had a focus on reducing unhealthy alcohol use through these brief motivational interviewing episodes, and we had very high engagement rates. So being able to reach people on the phone made it so that 97% of patients who are eligible after completing the full audit completed a session with one of our substance use navigators, social workers, and that 72% of people went on to complete 2 sessions. The mean audit score reduction, so looking at the patient-reported outcome measure there, was 4 at 3 to 6 months, so this was effective. And this had an equitable impact across diverse patient populations, especially Hispanic and Latinx folks. And so just to give you a visual sense of what this looked like, right? We screened everybody at one of our health centers with the audit C. 18% of people were positive. Of those, there was a substantial drop-off in those who completed the full audit. And remember, this is a general healthcare setting where people are coming in for what they're coming in for. And a little less than 1 in 5 completed the full audit, which was the initial full evaluation. So opportunity for improvement there. And still, for those who did engage in the BI, the brief intervention, whether somebody's audit score is less than 12, so that's typically associated with mild to moderate alcohol use disorder, or greater than 12, which is often severe alcohol use disorder, there's very high engagement. And then the average decreases in the audit scores were substantial for both of those groups, and broken out here between those, again, with the mild to moderate and severe. The second opportunity for improvement that we identified here was that only about 15% of folks who had that very high audit score and engaged in the brief interventions, only 15% got on medications. And so in our real world experience of implementing a telephone-based screening, brief intervention, and treatment in primary care or referral to our FQHC-based addiction medicine clinic, only 15% of folks ended up on medications for AUD, which we know are effective and underutilized, and which is slightly better, but consistent with other data indicating this is a big opportunity for improvement, and telemedicine is probably going to be part of that improvement strategy at most of our health systems. For time, I'm looking at time and thinking, this is a good reference, JAMA describing what treatment for alcohol use disorder for those at highest risk can look like. This is almost all doable in primary care. So all right, so the case summary. This is a 47-year-old woman who overcame pandemic challenges, survived opioid use disorder, which is in remission on buprenorphine, and risky drinking with the help of innovative telemedicine models of care. And in this last part of the vignette, the brief negotiated interview and then brief interventions like this are typically a couple of sessions where MI tools are used to come up with patient-centered goals and to support people through change. And for most people, again, who drink too much or drink at a level that puts them at risk for cancer and other higher risk for cancer and other health consequences, we know that these brief behavioral interventions can be very effective, as it was in this case. All right, the final two slides here are talking about managing our own telemedicine transitions. And these are direct quotes from providers who are talking about their experience of this transition to telemedicine. One shared that virtual visits have been a joy. I know my patients much better and outcomes are improved. Another shared that I like to connect with my patients in the room, the body language. It's hard, right? We can't give hugs. That's what we do. We connect with patients. Telehealth is not the same. As I was preparing for this talk and thinking about it, I thought, I'm feeling both of these. I'm having a real ambivalence as a clinician about change. And in my clinical practice, this is AUD care via telemedicine and buprenorphine care via telemedicine. And I think both are true. That, well, outcomes are better and we're meeting patients where they're at better. And often it is just so cool to be on a video visit with a patient and for them to show you what they've been able to achieve in their recovery and what their life looks like or what their challenges are, frankly. That can be very meaningful. And sometimes I miss the connection that happens with in-person visits. And I think we're in a space where we're all figuring out our policies for our clinics and what clinical practice looks like. And I hope that just the meaning that's associated with doing this incredible work is part of the considerations we're all making as leaders in this space. And how do we support our workforce who are dealing with kind of both sides of this? When I was dealing with this, I actually came across this great talk that's part of this series from Dr. Brittany Houston, who talked about recognizing COVID-19 related compassion fatigue and enhancing resiliency. Her talk's available at that QR code. Her take homes were that awareness of continued impact of collective trauma and healthcare workers' specific trauma is important. Compassion fatigue can show up in many ways, and individual interventions just aren't enough to address compassion fatigue and inspire resilience. So I thought, what does kind of resilience look like? One of the great frameworks Dr. Houston offers is, sort of this equation that moral injury is what you know or expect your patient deserves minus what you're able to give them. And I think these telehealth innovations might lessen our moral injury, right? Do we have more resources to meet our patients' needs? Is the fact that we can deliver this care over video chat or phone, does that kind of close that gap? And do we also miss out on something as providers along the way? So I really encourage you to check out Dr. Houston's talk. And with that, I'll just summarize. SUD-related morbidity and mortality worsened during the pandemic as we are hopefully starting to turn a corner, and that innovative treatment protocols improve outcomes without compromising safety or quality, including methadone take-home policies, telemedicine for buprenorphine prescribing and approaches to screening and treating the alcohol use. I will leave this up here. If anybody's, we'd love to have more folks join our CSTAT TextRx sessions every second and fourth Thursday afternoon. Our last was yesterday, so we'll have another one in 2 weeks. And I'll leave this up as I stop sharing, and we have some questions we can discuss.
Thank you, Dr. Weems. We already have an interesting question here. Someone is asking, you talk about unhealthy alcohol use. Could you describe what healthy alcohol use is?
This is, I think part of the joy, like both the joy and the challenge of being in a primary care setting like I'm in, is that answer is very different from person to person. From a cancer perspective, the facts are what they are, and there's no safe amount of drinking when it comes to alcohol related cancer risk. And we know that people who are drinking above certain thresholds are at much higher risk of other negative health outcomes related to drinking. Things like liver disease and like injuries related to alcohol use, cardiovascular disease, particularly atrial fibrillation. Like there's a lot of things that can go wrong with much higher levels of drinking. And of course, alcohol use disorder, which we all see, right? It takes people out of who they are and it takes them away from their families and communities. So I think patients are typically receptive to sort of heavy-handed recommendations of abstinence. That, we know that that's in the MI world, right? That's likely to evoke sustained talk. So I don't know. I obviously have a lot to think about when it comes to, is there a healthy level of alcohol use? But I think generally getting to know our patients where they're at and understanding what that answer is for them is a great place to start.
Thank you. We see another question here. What steps can providers take to incorporate telehealth-based SBIRT into their practices?
That's a great question. So this week at the health center, we're again, it is very particular to your setting. One great step to understand first with your operations colleagues is what is reimbursable, and then what are the clinical support tools we can offer clinicians to make sure that the work we're doing supports your setting of care. So there's a lot of steps we can take as clinicians, right? The guide that I provided earlier from PCSS is particular to buprenorphine care. And I can do some work to help find more. There's likely something out there, I'm not aware of it off the top of my head, for SBIRT utilizing telemedicine. But I think the setting is very, very important, and there's likely already in place policies and procedures related to this. I think that's a great place to start. The state of Texas, there's state-specific, role-specific guidance there. I think that's a great place to start.
Yes, and I realized, I mean, I saw you mention something that it's kind of a point of contention for some people. You talk about the decrease in rates of self-discharge for people who use or who go home with methadones. Could you extend a little bit more about that?
Guys, about the take-home.
Yeah, you mentioned that there is a decrease in self-discharge, like people are more prone to stay under under care. Could you explain a little bit more about that part? Thank you.
Yeah, so we see often with our patients is that the system of care for methadone often isn't continually accessible for our patients. So, in this case, what I try to draw out is a lot of our patients are in the trades or have gig work that takes them out of town. Getting to a clinic 6 days a week or even 2 or 3 days a week with very limited take homes makes it so people are making this really challenging decision between continuing to access care that's helping them get their life back and then living that life, doing things like getting back to work. And we know people who are on the more severe end of that spectrum I showed earlier, who are stabilizing are at very high risk of returning to use, and they're at very high risk of overdose in that setting. And so the current state of before this updated guidance came out is that, you know, for people who can make it into methadone to overcome all those barriers and pass the threshold into care, many of them are retained. However, for many people, that threshold is insurmountable. And so with these change in the criteria for take homes and an increase in the number of take homes, what was observed by a number of investigators looking at different populations was that patients stayed in care longer. And I think it just makes sense. It's one of those great research findings that sort of backs up your intuition, like, oh, if we get people their medication, get out of their way and let them live their lives, they're able to stay in care longer. The things that we're holding back, change in methadone regulation, concerns about diversion, concerns about methadone morbidity and mortality. So people being exposed to methadone who are not opioid tolerant, and negative health outcomes related to that, which are really real concerns, community health concerns. Thankfully, the data did not show an increase in those negative health outcomes. So to sort of summarize, patients can now access care that is more individualizable, and it's very different at different NTPs, but it can be more flexible, and some of the barriers to continuing on with care can be overcome earlier, implementing this guidance from SAMHSA and the way the state in the state of Texas that is currently possible. Hope that helps.
Of course, thank you. And we want to take some time to thank you really for participating in our webinar. This was great information, and I want to remind all participants that this material will be sent via email after this session. So before we leave, let's move to some announcements, and let's remember that the Center for Substance Use Training and Telementoring CSTAT offers technical assistance. This is a free service for all of you in the community. If you're interested, just complete our TA form at our website, cstat.utesca.edu, and we'll be here for you. We'll help you. If you want to claim CMEs, just text the code ATTEND 100 981 96 to the phone that you see on the screen. And if you're looking for your CEUs or certificates, please remember to complete the post-session survey. We're sharing it with you right now. And after that, you should expect approximately 2 weeks, around 2 weeks, for you to receive your certificates. Next. And it's that time of the year again. The Texas Substance Use Symposium 2025 is here. This year is going to be in El Paso, Texas, February 27 and 28. If you want to register, please go to the website, txsus.org. Next. And I know that some of you want to sponsor or exhibit our symposium. For that, please go to our webpage, txtexas.org/sponsor Texas. And there is still a variety of packages and options available for those of you who want to be sponsor or exhibitors. We're really looking forward this year to the symposium. And next. Well, next month, Thursday, January the 23rd, we'll have our next session, and we'll see you here. And thank you to all of you. Again, remember to answer the post-session survey. This has been a great session. We'll see you next month. Thank you, and have a great rest of your day. Thank you all.